I just want to take a little detour here because I talked to these guys before we went on the air, and you were telling me about viral therapy, embedding a new genome into the liver, and suddenly patients making factor VIII.
Yeah, so I mean, gene therapy has been something, I feel like we keep saying in 5 years it's going to happen. They say that every couple of years, but I think really in 5 years it's going to be a reality. And certainly at your center, I know they have these studies available, and we do too. And so they take, like you said, they'll take specific virus that's usually non-pathogenic. They strip out all the bad things. They insert, and they insert the factor VIII or factor IX gene. And a lot of them have developed where they don't insert into the genome, and so it goes into the liver cell. So you inject it just like a regular injection, IV injection. It's been tagged to find the liver. It goes into the liver and forms what's called an episome, so circular DNA outside the nucleus. So it doesn't integrate, or its integration rate is extremely low. And you hope that it'll continue to produce factor as long as you have your liver. And so you have to wait for the liver to be fully grown. And so typically we're not going to be doing this until they're older. So again, you have that time period, the first 18 years of their life, where you got to give them something. But I mean, there are trials where patients have 50% factor VIII and people with factor IX levels in the 30-40% range. And so it's becoming a reality. Gene therapy will be available for multiple diseases in the future.
But you were talking about cost.
Yeah.
Nobody knows exactly what gene therapy is going to cost. Is it going to be $1 million per patient or whatever? But
it's just once.
Yeah,
it's a one-time.
Exactly.
Yeah.
So you kind of do the math, and
but we don't know. Like some
it.
patients may get 100% factor, and some patients may get 2% factor. And do you base it on that? And as we know, people have insurance when they're 18 is not the same insurance when they're 35, and we don't. And so sometimes people don't want to pay for future benefit, and so that's why it makes it complicated in the U.S.
And let me ask a really naive question. If you can't do this gene therapy till they're 18, however, they've had a lifetime of non-exposure to VIII. Suddenly they get VIII. Why won't they develop blockers to that VIII?
Sure.
Now that they're making their own.
Well, I mean, typically they're done in previously treated patients we call PTPs, and so we know that patients that receive factor, and if they're able to get past that first 20 to 50 exposures, the chance of them developing a neutralizing antibody afterwards is very small. There's a little bit of a peak as they get older, as anytime you see older patients, their immune system changes, so we're talking 70, 80-year-olds that may develop that. But we've done these big studies, 400 or 500 patients have received and switched products, and they don't develop inhibitors. And so we haven't seen that with gene therapy, and that's, again, another reason why it probably isn't going to be feasible in young children.
I got you. Now let's talk about, again, the nuts and bolts from a pharmacy perspective, because I know you guys are boots on the ground, or boots in the mail, if you will. But you're getting the granular structure of all of this. How frequently do you review the outcomes with the patients in your practice? Do you do this on the phone? Do you do this in person? Do you text them? Lead me through some of this.
Well, we usually call them every month. Some people
so old-fashioned, you call them?
Yeah.
You don't
like
text
audio.
We call them. Some people have patient reps in the field that contact them, and the rep will email us
My
their
daughter would call you
assessments.
Neanderthal. Dad, nobody talks to anybody anymore.
But we do have some younger patients that won't answer their phone,
I
and
knew
they
it.
want us to text them.
I knew it.
So an app might be a good thing for them.
It totally works.
We do have a pharmacy cell phone, and we do text people.
You do?
Yeah.
Honest,
But
we
you
do.
have to.
How often? How often do you follow up? What do you do with the data? When do you intervene? Do you go directly? Do you call the doc? Help me out here.
Well, as Lacey said, I think we probably all call once a month, or we have patients call us once a month. And as I said earlier, we kind of just go through a list of questions and, determine kind of what's going on with them that particular month. And then, at least at our center, we can certainly communicate that back to the care team, talk to the nurses, say, John Doe has had 2 bleeds in the last month, and his pharmacokinetics says that he shouldn't be bleeding, and so they'll call and go through over that.
Do you have part of your algorithm for, oops, we didn't get a call?
We have a calendar, and we know when patients are due.
So good old-fashioned, strategies still work, right?
Because that could be very, very good or very, very bad.
Yes.
Well, we know if they're being compliant or not.
Yeah.
So if they're not refilling in a month,
That's
you
right.
can call them and ask them why. How many doses do you have on hand? 10. Why do you have 10 doses on hand?
That means you missed 10 doses. Yeah.
Or
so.
it could be a patient who had soccer season and soccer's over, and now he's not infusing as much.
Okay.
Yeah, and what our business person at the pharmacy, she actually puts together what we call a kind of a possession time.
What is a possession time?
So it's kind of a rate of how often have we filled, and so how much has a patient used. And so we can kind of tell if they have a possession time of 1, everything that we've sent them, they've used.
Okay.
But if they have a possession time of half or 0.5, they've only used half of what they were supposed to. And so that kind of communicates back to kind of our care team. So when that patient comes in for an appointment, they know what kind of conversation to have with them.
Yeah, I mean, we rely, because we can't see patients that often. I mean, we have a very busy clinic, probably have the 2nd or 3rd largest in the country. So we're seeing hundreds of bleeding disorder patients. And we don't typically see them more often than every 3 months. So we heavily rely on our pharmacists, and they call us and say, Johnny, he's got a lot of doses at home. I think something's going on, and they'll alert the social worker, and maybe something's going on at home. Maybe the parents are getting divorced, and so we have to know everything about these patients. I mean, we know everything about them.